management of primary open angle glaucoma. We have already discussed and diagnosed that how we will diagnose a case of primary open angle glaucoma. We discussed that the visual acuity it remains normal till very late stages of the disease. We have also discussed that there may be increased in IOP greater than 21 millimeter of mercury at any time of the day. We have also discussed that the optic nerve is damaged and there is cupping of the optic nerve which is diagnosed on ophthalmoscopy and also on OCT. Also, there are very important thing, there are visual field defects. So once we have diagnosed a case of primary open angle glaucoma, next stage is how we are going to manage it. So today we will discuss management of primary open angle glaucoma. Today it's a new experience. We are transmitting this online. You can view the lecture, you can listen to the lecture while you are sitting at your home, and we can deliver it at any time of the day. Anyway, it's a good experience. You know one thing, these are not vacations. Basically, the government has asked us to close all the campus to avoid the spread of coronavirus. So the teaching must not be disturbed. So this is our endeavor to keep on teaching you, keep on interacting with you. Well, definitely it's difficult. We cannot mark your attendance. So it doesn't really matter because the tests will be taken in time. And if you pass the test, your attendance will automatically be marked. If you don't pass the test, you will be considered as absent from most of these lectures. Now, that's listening to the lecture online. If you are sitting in your home, your lectures, you are listening to your lecture, so all these things they can happen. Anyway, I was reading somewhere that when bubonic plague, there was quarantine due to bubonic plague, Shakespeare wrote one of his most famous plays while he was limited to his home. Similarly, you should make full use of these vacations, so-called vacations, and you should keep on studying. We will help you, we'll send you lectures. And another thing, I will request all the students who are going to wards for their clinical training, they will make WhatsApp group of their batches, respective batches, and the batch representative BR, she should contact their teacher. All the teachers will be in that group, and during that clinical hour, that is from 11 to 2, you will be interacting with your teachers. They will give you scenarios and they will be in touch with you. Yes, and the attendance will be marked according to your contribution. ये आप ज़हन में रखें, अगर आप उस दौरान कंट्रीब्यूट नहीं करेंगे, क्वेश्चन के जवाब नहीं देंगे, तो आपकी अटेंडेंस मार्क नहीं होगी. Now coming back to treatment of glaucoma. Glaucoma is a complicated disease, and one thing which is very important in glaucoma is the intraocular pressure. We cannot control everything. Right now we can just control one thing, and that is we can reduce the intraocular pressure. If the intraocular pressure is high, we can reduce it. If it is normal, we'll further try to reduce it. So we can do everything to reduce intraocular pressure. Number one, we can give medicines. We can give eye drops. The pressure may be reduced or not. If it is not reduced, or if there are complications with drop, we can give oral medications. And if patient cannot tolerate the oral medication or our target is not achieved, then we can go for laser treatment. And if laser treatment is not enough, then we can go for surgery. So once again, I repeat, the only thing which we can do in primary open angle glaucoma is to reduce the intraocular pressure. Reduction of intraocular pressure can be achieved by drops, by oral medications, by laser surgery, or by surgery, conventional surgery. So we will have to weigh the benefits of individual drops or benefits or disadvantages of drops with other treatment modalities. Now, first of all, in drugs, the most oldest time tested drugs are the beta blockers. There are 5 groups. One are beta blocker, sympathomimetics, miotics, prostaglandin analogs, carbonic anhydrase inhibitors. So these carbonic anhydrase inhibitors, they may be topical or they can be systemic. What we want to achieve when we give drops? Number one, whenever we select a drop, number one, do they reduce the intraocular pressure? And how long is the duration of effect of that particular drop? Then, after using the drops, we'll keep on checking the visual fields. This is a complicated disease. We are just targeting one segment, that is reduction of intraocular pressure. But the symptoms or signs, they may remain there or even they worsen. So we'll check whether the visual fields are preserved or not. Then there is no loss of effect of that particular drug with time. Then other treatment modalities, are they compatible with other treatments? Then most importantly, the adverse side effects, lack of systemic effects, and the compliance of the patient. There are medications which are very difficult for the patient to instill. They do not comply. If they do not comply, we'll have to go for other modalities. Similarly, even topical drops, they can have severe systemic side effects in patients who are prone to those side effects. So again, we'll have to change or tailor our treatment modality according to all these things. You can read it or you can write it down. Intraocular pressure reduction, duration of effect, preservation of visual field, loss of effect, compatibility with other treatments, lack of topical adverse effects, lack of systemic adverse effects, and compliance of the patient. Now, carbonic anhydrase inhibitors. Now, carbonic anhydrase inhibitor, it catalyzes the chemical reaction where bicarbonate ions, they are actively secreted out of the ciliary epithelium. And when they are actively secreted, the osmotic gradient develops and then rest of the ions and water, it flows out of the ciliary epithelium and aqueous is produced. So this enzyme is very necessary for production of aqueous. So there are two things. When we reduce intraocular pressure, either we can reduce the production of aqueous humor or we can increase the outflow of aqueous humor. Generally the topical, not all, generally the topical drops, they reduce the production of aqueous. Few drops, they increase the drainage of aqueous. In surgical procedures, they increase the drainage of aqueous humor from the eye. So these carbonic anhydrase emitters, they are also used systemically and they are used topically. But if we use systemically, there are so many side effects that if patient comes to you without saying that he is having some problem, it means he is not using these carbonic anhydrase inhibitors, which is istazolamide, diamox, or we call it AZM tablets. So with the systemic use of carbonic anhydrase inhibitors, the side effects are universal. This is lack of appetite, gastric disturbances, paresthesia. There is tingling sensations of the fingers, gut disturbances. He feels fatigue, he feels depression. There may be formation of kidney stone and aplastic anemia can occur. So nowadays, systemic carbonic anhydrase are either used for a very limited period of time when other modalities are not available. Generally, they are discouraged. Moreover, here in Pakistan, it becomes very difficult nowadays to get these carbonic anhydrase inhibitors. The second thing, these carbonic anhydrase inhibitors, they also come in topical drops. So these are very good. Their side effects are minimal. Still patient can have side effect, but their side effects are minimal in topical drops. And most of the time nowadays carbonic anhydrase inhibitors are used as topical drops. Other one of the oldest drops used for glaucoma are parasympathomimetics. They are also myotics, pilocarpine. So that is the oldest glaucoma treatment available. This used to be the only treatment available. But as you know, what it is with this contraction of the ciliary muscles, when these muscles, there is a contraction, there is a pull on the trabecular meshwork. Because of the pull on the trabecular meshwork, few of the bands, they are pulled, so other pores are opened up because of that pull. But the most uh, bad side effect of pilocarpine is number one, that it causes meiosis. The pupil is extremely constricted. So it becomes very difficult, although these, as you know, this primary open angle glaucoma, it is more in older people and they may have a bit of cataract in their eyes. So in the evening, the pupil will not dilate and they won't be able to see. So it becomes difficult for the patient to see in the evening or in the dark. Then there can be spasm of accommodation that the eyes, they do not relax. The eyes are set for near vision. So that far vision is disturbed. Then there can be retinal detachment. Why retinal detachment? Again, this ciliary body, the muscles, they contract and they can pull the retina in the people who are predisposed to retinal detachment. Then again, fourth thing is the duration of action is very short. So I'll try to make a diagram to show it to you. This is cornea. Well, iris. Now these are, somewhere here is the ciliary body. Now one side effect is that the pupil is constricted. Now this pupil is constricted. This is pinpoint pupil. So in the evening, it becomes very difficult for the patient to see. Secondly, there is spasm of accommodation. The lens become globular because of accommodation and the near vision is increased and far vision is decreased and eye become there is spasm of accommodation. Thirdly, there is pull on the retina because of the constriction of, and there can be retinal detachment. So these all are the complications of use of myotics. So myotics are rarely used nowadays because in cases of primary open angle glaucoma, these are rarely used. So these are all are the side effects of parasympathomimetics drugs. They are still used for closed angle closure, which we will study later on, but they are rarely used in primary open angle glaucoma. Now, sympathomimetic drugs. These are alpha agonists. As I told you, the beta blockers, sorry, the sympathomimetics, beta receptors, they increase the production of aqueous. That's why we give beta blockers. Alpha receptors, they decrease the production of aqueous. That's why we give sympathomimetics or alpha agonist drugs. Their dosage is twice a day. They decrease production of aqueous and also they increase the drainage by uveous scleral outflow. I told you that uveous scleral outflow is also important. They contribute just 10%, but in glaucoma they become important. This flow becomes important, and these drugs they increase the drainage of aqueous with through uveous scleral outflow. Moreover, it is claimed that these alpha receptors they are effective when alpha adrenergic drugs are given. They are effective in retention of the visual field. They maintain the visual field because they are helpful in the health of retinal nerve fiber layer. Beta blockers. The beta blockers, again, beta blockers have been the most uh, popular drug for primary open angle glaucoma. It has been the most popular drug for last 3-4 decades. They decrease the production of aqueous. Dosage is twice a day. And one of the very important thing is that they cause bronchospasm and bradycardia. The spelling bradycardia के गलत है, ये आप ठीक कर लें. Bronchospasm and bradycardia. So if the patient, you must take the history of the patient before prescribing beta blockers. That is, if the patient is having asthma or any respiratory problem, you must be very careful in giving beta blockers. Then you also check the pulse of the patient. If the pulse is below 60, I'd never give beta blocker eye drops. And I tell you one thing, any patient who is susceptible for any side effect, whenever you give a drug, ask the patient to put his finger on his lacrimal sac or area of the lacrimal sac for about 1.5 minutes so that there is minimal systemic absorption. So these drugs, they have systemic eye drops. These are eye drops, but their side effects are systemic. That's why you will always ask the patient to put a finger over his lacrimal sac so that the drops which you instill, they do not go into the nasal mucosa and are not absorbed by the nasal mucosa through nasolacrimal duct. So that is one way of reducing the systemic side effects of a local drop. Once these are all the drugs, again one drug is missed, that are prostaglandin analogs. The prostaglandin analogs, again, these prostaglandin analogs, they are in many places. Now it is the first line of treatment of primary open angle glaucoma. Its side effects are the stinging sensation, the redness of the eye, inflammation of the eye. Moreover, in our setup, in dark skinned people, it causes increase in the size and thickening of the eyelashes. So eyelashes become so long that they turn inward and trichiasis is caused and they can cause damage to the cornea. That's why, well, in the West, they are still used, but it's not the first, generally it's not the first line of treatment here in Pakistan. Then comes, if there are systemic side effects, there are limitation of using drops, or the compliance of the patient is poor, then we'll have to go for surgery. One is laser trabeculoplasty. In laser trabeculoplasty, 50 to 100 burns, they are applied, I'll show you, at this area on the trabecular meshwork. They are applied to trabecular meshwork, and because of these burns, there is scarring of the trabecular meshwork, and because of scarring, there is pull on the adjacent part of the trabecular meshwork, and pores of the trabecular meshwork, they open up and the drainage of aqueous is increased. तो लेजर ट्रेबिकुलोप्लास्टी क्या करेगी? इंक्रीज करेगी पेशेंट के एक्वस की ड्रेनेज को, ठीक है ना. लेजर ट्रेबिकुलोप्लास्टी इट विल नॉट डिक्रीज द प्रोडक्शन ऑफ एक्वस, इट विल इंक्रीज द ड्रेनेज ऑफ एक्वस थ्रू द पोर्स. वो कैसे करेगी? When we'll apply laser, there will be scarring of part of the trabecular meshwork, and because of the scarring, there is pull on the adjacent part of the trabecular bands. So because of these pull, the pores will open up and there will be increase in drainage. Let's see. But I don't think.
Two types of laser procedures called argon laser trabeculoplasty, known as ALT, and selective laser trabeculoplasty, or SLT, are used for patients with open angle glaucoma. These lasers surgery are used to treat the drainage system of the eye. Notice the trabecular meshwork.
Yeah, it is applied.
System is designed to improve the flow of fluid out of the eye, helping to lower the Two types of laser procedures called argon laser trabeculoplasty, known as ALT, and selective laser trabeculoplasty, or SLT, are used for patients with open angle glaucoma. These laser surgeries are used to treat the drainage system of the eye, known as the trabecular meshwork. Treating this area of the eye's natural drainage system is designed to improve the flow of fluid out of the eye, helping to lower the pressure.
Partial thickness. Here, this is the incision is given here. This is retracted. So this is partial thickness. Partial thickness is retracted. On the limbus, it is retained, and here, this is the deep part. Then we make a hole in the deeper part of the sclera. Here, we will make a window here, so that fluid from the anterior chamber, it goes into this partial thickness, and then it goes out into the conjunctiva. ये बनाया deeper window, खोल दी, इसके बाद इसको partial. Then we make a iridectomy. There is iris here. We make a iridectomy so that the fluid from the posterior chamber, it comes into the anterior chamber if pupil is blocked through this iris hole, and then it is drained under the conjunctiva, and then conjunctiva is closed. I'll show you the video.
Surgery begins with the preparation of a limbus-based conjunctival flap.
This is conjunctival flap.
After incision of the conjunctiva, Tenon's layer is grasped and incised until the sclera is exposed. Adhesions of Tenon's layer with the corneoscleral junction are cleared with a pair of blunt scissors. Surgery begins with the preparation of a limbus-based conjunctival flap. Circular cell sponges soaked with the anti-metabolite mitomycin. After incision of the conjunctiva, Tenon's layer is grasped and incised until the sclera is exposed. Adhesions of Tenon's layer with the corneoscleral junction are cleared with a pair of blunt scissors. Width of 4 mm for the scleral flap. The edges of the flap are incised to approximately half of the scleral flap. Anti-metabolite application. Before scleral flap dissection, 2 half-circular cell sponges soaked with the anti-metabolite mitomycin by tangential preparation within the sclera using a crescent blade. Irrigation. The conjunctiva is retracted, the sponges removed, and the area is then irrigated with saline solution. Acetylcholine injection. Flap preparation. After marking the width of 4 mm for the scleral flap, the edges of the flap are incised to approximately half of the scleral thickness. Freehand dissection is carried forward uniformly into clear cornea, anteriorly to the trabecular meshwork. Now the scleral flap is constructed by tangential preparation within the sclera using a crescent blade. The flap should be dissected up into the clear cornea.
Deeper window. Now, partial thickness flap will be closed.
Acetylcholine injection. A paracentesis is created and acetylcholine injected into the anterior chamber to constrict the pupil for iridectomy. Trabeculectomy. During trabeculectomy, a scleral block, including some trabecular meshwork, is excised. The anterior incision is in clear cornea and the posterior incision near the scleral spur.
Fluid यहाँ से आया, through peripheral iridectomy anterior chamber में गया, और यहाँ से drain होगा.
Iridectomy. The iris is grasped and pulled, and a section of the iris is cut using scissors. This forms a triangular opening in the iris called iridectomy.
I will try to make a diagram also.
Aqueous humor pours out from the anterior and posterior chamber. Flap fixation. 3 nylon sutures are used to secure the flap.
Now you see,
If the flap is adapted too tightly, outflow is restricted and post-operative intraocular pressure is high. If the flap is adapted too loosely,
I'll try to show you. Now this is cornea. This is sclera. Sorry.
outflow test. When injecting saline solution through the paracentesis, the anterior chamber is reformed. Aqueous can be seen to escape under the scleral flap.
This is iris.
Conjunctival sutures. The conjunctiva is repositioned. Tenon material.
And this is lens. So fluid
filtering bleb formation. When injecting saline solution into the anterior chamber, a conjunctival filtering bleb is formed and the wound is checked for leaks.
This anterior chamber, it goes under the conjunctiva here. So this is basically trabeculectomy, is all about trabeculectomy. There is conjunctival bleb is formed. A bleb is formed under the conjunctiva where this fluid is accumulated and then it is drained out of the conjunctiva or is evaporated into the conjunctiva. So this is all about management of glaucoma. First of all medication, then laser trabeculoplasty, and third is trabeculectomy. So that's all for today. Thank you very much.